Hello, good afternoon. Good afternoon to all of you. Namaskar.
Yes, sir. Good afternoon.
Good afternoon. You are listening? Are you able to listen me?
Yes, sir. Sir, you are audible, sir.
Yeah.
Now your slide is visual, sir.
Slide are visible.
Yes, sir.
So can we start or we have to start at 3 o'clock? 5 minutes left.
Sir, start at sir 3 o'clock, sir.
Yeah. So we will start at 3 o'clock.
Okay, sir.
Thank you. ये ऊपर वीडियो कुछ बंद कर दे थोड़ी अभी तो बंद कर लो ना यार 3 बजे चालू कर देंगे वीडियो भी ऑफ कर सका आ पाएगा ओके अब आगे करने के लिए So I am ready, हाँ. बहुत तेज आवाज आ रही है ना. स्पीकर बंद करते हैं.
Sir, now you can start, sir.
Yeah. So good afternoon to all of you, all listeners. Today's the topic allotted to me by ICP people is macrovascular complication of diabetes. At the onset, I will introduce myself. I am Dr. Mahesh Dave, working as senior professor in Department of Medicine at RNT Medical College, Udaipur. So many things are with major achievements, but I was awarded with Hamasha Award, Rotary Club Awards, and other awards. A chapter in monogram in viral diseases, and around 50 to 60 papers in various national and international journals. At the outset, I will thank ICP for providing me this opportunity to speak on macrovascular complications related to diabetes. As all you are aware that diabetes is one of the major problem worldwide. And we all aware that India is one of the capital for diabetes mellitus. When we were a student in earlier 2000s, in 1994, 95, 96, the people were predicting, when we were attending the conference, people were predicting that very soon diabetes will be the hub. India will be the hub for diabetes, and scenario is absolutely correct. Now what data is showing that there is around 1,000 101 million of individuals with diabetes are there in India. Worldwide, there are 828 million of the cases worldwide, out of which 1/8 part is in India. India is probably the second leading country after China is having diabetes. How will you define diabetes? As we all know that diabetes is a metabolic disorder, metabolic disease, which is characterized by chronic hyperglycemia, result to insulin secretion defect, or there is a insulin action defect. Insulin will not be effective, or both, which leads to disturbances in carbohydrate, fat, and protein metabolism. So whenever there is disturbances in insulin secretion or action, leads to all metabolic abnormality, leads to persistent hyperglycemia, leads to diabetes mellitus. Because it affects the metabolism, there are a lot of complications. It's a chronic disorder. And nowadays they are saying that this is a disease which is chronic inflammatory disorder. So inflammation is going all over the body, leads to a lot of complication. The important complication are microvascular complication as well as macrovascular complications. And today's my topic is deal with macrovascular complication. So in next slides, I will tell what macrovessels are, what microvessels are. But before going, little bit regarding history of diabetes. As we all know that diabetes is a chronic devastating disorders, which is multi-system involvement. Every system, each and every part of the body will be affected by chronic hyperglycemia or diabetes. So what little bit regarding the history. When I evaluated the history, I come to know that the first description of diabetes was there in Sushruta, 6th century BC, and it was labeled as prameha. The prameha simply means, pra means excess, meha means urine. In that century, 6th century, people were aware that there is an excess of urine person is passing, and that should be labeled them as prameha, and really now it is called diabetes. So how advanced Indian were, because they were aware of this disease earlier in 6th century. A great detailed description was there in Charak Samhita, and Charak recognized this disease, and he recognized around 20 type of diabetes have a description. And at the last they wrote that if diabetes is untreated, there will be a excessive sugar in urine, and they labeled as madhumeha. Madhu means honey, meha means urine. So urine will be like honey. It will be what today we called madhumeha or diabetes, which is classically characterized by excess of the urine and sweet urine, excessive sugar excretions or glucose excretion in urine. The first ever description of the diabetes was in Lord Ganesha. In ancient time, it is predicted that Lord Shiva described or depicted the treatment of this diabetes or prameha for Lord Ganesha, father of Ganesha, Shiva, first ever. And they say that in Ganesha, diabetes was there because of predilection to sweet, sedentary habit, and that of waist circumference. More will be the waist circumference, more will be the metabolic disorders. So this is all truth from where the journey started and where the journey is coming and where it will end, we don't know. What do you understand by the micro and macro refers to? Micro means definitely the small blood vessels, which includes capillary and arterioles involvement, where large macrovascular complication is related to complication to large and medium size involvement. The predominant large and medium size arteries are coronary artery, which is ultimately causing coronary artery disease, CAD. Cerebral arteries ultimately leads to CVA, cerebrovascular accidents, and large vessels like popliteal artery and dorsalis pedis artery involvement leads to a condition called peripheral vascular disease. So what macrovascular complications are? macrovascular complication are peripheral vascular disease called PVD, CVD, coronary vascular disease, and CVA, cerebrovascular disease, where that small vessel disease is involvement of renal arterioles lead to renal involvement like nephropathy, eyes involvement in the form of retinopathies, and then nerve involvement because the nerve supply with the capillaries and small vessels lead to neuropathy. So these are the complications divided into microvascular as well as macrovascular. In today's class, we are going to deal with macrovascular complications. So predominantly CVD, CVA, and PVD. So this is a diagrammatic representation of macrovascular and microvascular complications. It leads to cerebrovascular disease, it leads to cardiovascular disease and peripheral vascular disease, whereas microvascular involvement leads to retinopathy, nephro, and neuropathy. What are the cardiovascular diseases in diabetes? For macrovascular complication, the first heading is cardiovascular diseases. Cardiovascular disease is leading cause of mortality in individuals with type 2 diabetes, particularly in type 2. People with diabetes having 2 to 4 times higher risk of developing cardiovascular events such as heart attack and congestive heart failure as compared to those without diabetes. So I already said that one of the very important macrovascular complication is CVD. And in CVD, two important complications can occur. One is called ischemic heart disease or CAD, and second is congestive heart failure. And both are 2 to 4-fold higher in diabetic patient than non-diabetic patients. This is what the pathophysiology is. What happens? Why diabetes is associated with this macrovascular complication and why there is 2 to 4-fold higher. So the mechanism given is that there is chances of insulin resistant in diabetic patient. So whenever there will be insulin resistant, there will be increased level of insulin. Hyperglycemia, there will increase diabetes. So there will be increased sugar level. And this lead excessive free fatty acid formation. So insulin resistance means high insulin level, high sugar level, and excessive fatty acid. All these will lead to oxidative stress, PKC activation, and RAGE activations, which lead to endothelial damage. And whenever there will be endothelial damage, there will be decreased nitric oxide productions. Nitric oxide is predominant markers secreted by endothelium. Increase endothelin 1 and increase angiotensin 2. Decrease nitric oxide, increase activation of NF-kB, increase angiotensin 2, increase activation of activator protein 1. All these will what they lead to? Predominantly, they lead to inflammation and inflammatory cytokines will be increased. They will induce thrombosis, decrease fibrinolysis, increase platelet activations. They can cause vasoconstriction by which there will be hypertension. Vascular smooth muscle cell growth will be increased. As we all aware that insulin is acting as a growth precursor, it will increase the growth of vascular smooth muscles, which leads to atherosclerosis. The predominant hypothesis is atherosclerosis. So decrease in nitric oxide, chronic inflammation, endothelial dysfunctions, and so many these substances, inflammatory chemokines, leads to increased atherosclerosis. This atherosclerosis causing decreased lumen of coronary arteries, stiffening of the coronary artery. So whenever there will be increased flow, they are not going to dilate. And hence they will lead mismatch in the requirement and supply. So whenever there is a mismatch between supply and requirements, what they are going to lead? There will be increased oxygen supply, and this oxygen supply to myocardium is not fulfilled by the blood. Hence, the patient will present with coronary artery disease in the form of angina pectoralis in the form of ischemic heart disease or in the form of full-blown MI. This slide is depicting that the people of diabetes will have 5 to 10 years, will die 5 to 10 years before the people without diabetes because of CVD. They are saying that if somebody is having diabetes, the CVD risk factor is such that the person will die 5 to 10 years before the people without diabetes. They are twice, 2 to 3 times higher incidences of stroke, and they are to 15 to 14 times more likely to be having lower limb amputation. So you see the severity of macrovascular complication of diabetes. There is 5 to 10 fold death mortality rate is high, twice a rate of stroke is high, CVD is high, and 15 to 20 times amputation is high in diabetes versus non-diabetic persons. Mortality in acute coronary syndrome in diabetes versus non-diabetes. This slide indicates that the patient of diabetes mellitus has significantly high mortality rate from acute coronary syndrome as compared to non-diabetic. Short-term mortality 2 to 3 times higher in risk in hospital and 30 days mortality after ACH, acute coronary syndrome, compared to non-diabetic. This is Grace Registry and TIMI trial. Long-term mortality again with Framingham Heart Study and Dennis Registry. 1 year mortality in post-ACH is 40 to 50% higher in diabetic. 5-year mortality rates nearly double in diabetic as compared to non-diabetic. Recurrence of MI, heart failure, and sudden cardiac death are more common in diabetic post-acute coronary syndrome. Silent myocardial infarction due to diabetic neuropathy often delays the diagnosis, leading towards outcome. As we all aware that diabetes is one very important cause of painless MI. There are so many other causes of painless MI, but one very important and the most common cause of painless MI is only and only diabetes, where even patient is having MI and patient can't perceive pain, he will not visit to the hospital and there will be a silent attack or mortality. And hence, whatever these studies are suggestive that diabetes is having high rate of mortality, high rate of complications. And hence, today we are dealing or we are studying this, that this complication is very fatal complication of macrovascular complication of diabetes. Now the question arises, why post-coronary syndrome in diabetic is having high mortality? So the mortality is high, as you all are aware that there is extensive atherosclerosis because of diabetes. I already said the pathophysiology that there is reduced nitric oxide, there is endothelial dysfunction, there is chronic inflammation. So there will be extensive atherosclerosis. They are high risk of heart failure, 2 to 5 times higher to develop heart failure. Silent ischemia and delayed in treatment is one of the very important cause because of the autonomic neuropathies, which leads pain insensitivity. Then endothelial dysfunction and increased coagulability is another factors. Less favorable response to revascularization, chronic inflammation and insulin resistant promotes the plaque instabilities, increased plaque formation and increased cardiac event. So this insulin is not at all beneficial everywhere. It may have harmful effect because it can increase because of the hyperinsulinemia, insulin resistant, it can lead to lot of complications. Now there are so many predicted for cardiovascular disease and diabetes. One very important factor they denoted is HbA1c level. So HbA1c is the higher, more will be the cardiovascular event. In the next few slides, I will discuss regarding the biomarkers of cardiovascular events with diabetes. And one of the important cardiovascular, important markers, biomarkers, may be HbA1c. So many studies were done, hemoglobin 1c, along with mortality in diabetic patient and cardiovascular event, and they found a significant relations. This what the study is showing, that if glycosylated hemoglobin is less than 6, the mortality is 1. Progressively, there will be increase, progressive mortality over the 10 years follow-up in type 2 diabetes. is 2.5 times higher. This is UKPDS study suggestive that the relative risk is 2.5% higher in a patient who is having glycosylated hemoglobin between 9 to 10 as compared to less than 6. So you can see a gross difference between glycosylated hemoglobin level and relative risk. Relative risk to develop CVD. So what should be optimal HbA1c target in cardiovascular risk reduction? They are saying that HbA1c should be maintained less than 7 in an old patient, and it should be between 6 to 6.5% patient who are younger. Elderly patient with high CVD risk, it should be maintained between 7 to 8 to avoid hypoglycemia and death because of hypoglycemia. Because as age advances, hypoglycemic sensitivity will reduced, and hence you are not able to mark strong control of glycosylated hemoglobin between 6 to 6.5. So in elderly person, you have to maintain glycosylated hemoglobin between 7 to 8. So the next important part is how will we approach a patient of diabetes with cardiovascular diseases. So is a principle of medicine that everywhere, whenever we approach a patient, the first important part is history. So we should have take detailed history of the patients. So assessment of careful history for claudication to rule out PVD, angina, dyspnea on exertion, giddiness, vertigo for cerebrovascular disease. Then we have to go for physical examination. We have to see for atherosclerosis markers. So many atherosclerosis marker is there, including all pulse, blood pressure, everything will indicate atherosclerosis. And then the blood pressure difference between upper limb and lower limb is another marker. Carotid blue is another marker by which we can have an idea how atherosclerosis is there in cerebral vessels. So all these are very, very important. Other than peripheral arterial pulsations, ratio of ankle to brachial artery, systolic blood pressure, marker for subclinical peripheral vascular disease. Bedside autonomic function test, blunting of blood pressure response and heart rate response are another markers. You can go with ambulatory blood pressure markers and see there is a dipping is there, late night dipping is there or not. If late night dipping is not there, it predicts your cardiovascular outcome, that the patient will have poor outcome for cardiovascular disease. ECG, painless ST segment depression or elevation with LV hypertrophy. Stress testing are very, very important testing we should have to carry out. Ambulatory ECG monitoring, echocardiography, radionucleotide study, C for diastolic dysfunctioning, LV wall motion abnormalities. Laboratory investigation, C for microalbuminuria, which is thought to be the important predictor not for the renal disease, but also cardiovascular disease. Another very important hallmark is your inflammatory markers, like any inflammation like ESR you can have, C-reactive protein you may have, more will be the C-reactive protein, more will be the inflammation, more will be the cardiovascular and cerebrovascular diseases. So all these markers are very, very important, play important role to predict cardiovascular outcome or deaths or cardiovascular disease in a patient of diabetes. Carotid ultrasonography is helpful for subclinical carotid atherosclerosis to detect early. So this is a diagnostic approach: treadmill test, exercise stress test, echocardiography, coronary calcium scoring by CT angio, myocardial perfusion scan, and single photon emission promote CT scan are investigation of choice to detect silent ischemia in diabetic patient. As already said, the patient will have no angina, patient will have no chest pain. So how to evaluate these type of patient? So stress testing plays very important role in diabetes and CVD. Similarly, there are various biomarkers can be used to detect early coronary artery disease in non-symptomatic patients. This is what various biomarkers of CVD. You know, there are so many biomarkers which indicate so many things. One is called metabolic biomarkers, which include homocysteine level, lipoprotein A level. The chronic inflammation markers like white blood count, TLC, and inflammation is suggested by high TLC, lymphopenia, something like that. So white blood cell count, NLR ratio is an important marker for inflammation. Neutrophilic lymphocytic ratio, one very important marker. And lymphocytic platelet ratio, platelet lymphocytic PLR ratio are the another very, very important markers to show inflammation. So NLR and PLR. High sensitive CRP is another indication, high sensitive CRP. Then IL-6, then GDF-15. These are the important inflammatory markers which indicate that inflammation is going on. Serum creatinine and eGFR is important marker to rule out renal diseases. And rest all like BNP, ANP, arterionatriuretic peptide, important marker which indicate early congestive heart failure in asymptomatic patients. So if you go for ANP and BNP, brain natriuretic peptide and arterionatriuretic peptides, where these marker is needed when the patient is having no clear-cut symptoms and you want to predict the outcome of the disease and you want to diagnose the disease. These markers may be useful. These are called biomarkers of CVD in diabetic patients. So now the last component of cardiovascular disease is how will we manage? Because such a patient, I already said that there is 2 to 3-fold higher chances of CAD. There is around 5 times high mortality in CVD death in diabetic mellitus. They are having all prone to complication. If there is a cardiovascular disease occurs, then in diabetic will be more prone than non-diabetic persons. So management of CAD in diabetes required multi-dimensional approach, which regulate careful consideration of medication versus revascularization therapy. The first step in diabetic patient with CVD or with prevention of CVD is blood pressure control. These patients of diabetes, the goal for diabetes with hypertension is different with non-diabetic and hypertension. So this is a table which is showing that the blood pressure less than 120/80, non-pharmacological intervention is required, no drug is required. In diabetes with hypertension, no drug required when BP is 120/80. If it is 120 to 129/80, again non-pharmacological intervention is required. This is elevated blood pressure. Elevated blood pressure is defined as when blood pressure is between 120 to 130 or 129. If blood pressure is between 130 to 139 and diastolic is between 80 to 89, calculate your 10 years ASCVD score. This ASCVD score can be calculated by ready-made formula available on Google. So you can have detect the 10 years risk factor and risk reduction if it is more than 10 or less than 10, to start with the drug or not to start with the drug. But a patient who is having hypertension stage 2 means the blood pressure is more than 140/80, 140/90. You should have non-pharmacological intervention and drug therapy is definitely required. You should have to give definitely the non-pharmacological intervention plus drug when blood pressure is more than 140/90. When you calculate ASCVD scoring and if risk is more than 10%, again you have to give interventional non-pharmacological intervention plus drug. If less than 10, only non-pharmacological intervention is needed. This is what the non-pharmacological intervention. I said that the pharmacological indication are there and pharmacological intervention will depend upon which drug you are going to use. In my opinion, the first drug will be ACE inhibitor versus ARBs. This is a drug of choice, definitely, that you should have to use. The non-pharmacological measures including DASH therapy, where there is a low sodium diet, consume a diet rich of fruits, vegetable, whole grain, low dairy product, fatty product, reduce content of saturated and natural fat. Reduce sodium intake by 1.5 gram per day, optimal goal, but you can reduce by 1 gram per day even. Enhancement of intake of dietary potassium. They are saying that if you increase the potassium intake 3.5 to 5 milligram per day, your blood pressure will come normal. Then physical exercise, including aerobic exercise, 90 to 150 minutes per week. Not for a week. At least you should have to do exercise 5 days a week. So total will be around 150 minutes in a week. Dynamic resistant exercise you can do, isometric resistant exercise you can do. And they are saying that the moderate amount of consumption of alcohol, who drink alcohol, reduce the alcohol. If somebody is drinking heavy alcohol, he should have to stop because it is a predictor for cardiac disease. He should have to do less than 2 drink daily, and woman recommended is less than 1 drink daily will reduce cardiovascular outcome in diabetic patients. The second important component is that you have to manage lipids in diabetic patient to reduce CVD, cardiovascular disease death. And for that, what goal they are giving? For the primary prevention, if LDL is more than 190 milligram per deciliter, lifestyle modification plus high intensity statin can be used. High dose intensity statin means it is usually to 40 to 80 milligram of your atorvastatin you can use, or 20 to 40 milligram rosuvastatin you can use with lifestyle modification. If LDL-C level is between 70 to 190 without diabetes, you calculate again ASCVD scoring and treatment will be according to that. If LDL-C level is between 70 to 190 with diabetes mellitus, if there is no diabetes mellitus, then ASCVD scoring you have to do. Otherwise, again, if it is with diabetes with 70 to 190, even you have to start with statin, and that low dose statin in the form 10 to 20 milligram atorvastatin with lifestyle modification you can require. And if there is familiar hypercholesteremia, then you have to give low molecular weight. This you have to give lifestyle modification along with statin you can go with. So they are saying that if there is a diabetes and LDL cholesterol is between 70 to 190, you should reduce LDL-C by 30 to 50%. 30 to 50% simply means that if somebody is having 200 milligram per deciliter LDL-C, then 200 multiply by 50%, it comes around 250. So you have to come to the normal level around 70 to 80 will be the recommended LDL cholesterol. The third component after managing lipid, the third important component comes to be aspirin. Whether in all diabetic patient to prevent CVD, you give aspirin or not. So for secondary prevention, answer is yes. In all the patient who is having one episode of ischemic heart disease or MI, lifelong aspirin is indicated. So for secondary prevention, yes. For primary prevention, not clear-cut guidelines, but the European guideline is saying that if patient is having high risk ASCV scoring more than 10 or age is more than 40 years, low dose aspirin can be used. You can give low doses of aspirin in these patients. Otherwise, for secondary prevention, aspirin should be used in all patients. Concern of cardiovascular risk in anti-diabetic. Now the comes to be diabetes. Which diabetes drug you should have to use to prevent CVD risk factors and CVD, cardiovascular disease? All drugs are not ideal in diabetes and CVD prevention. They are saying that the sulfonylurea, glibenclamide, glimepiride, and gliclazides is having increased chances of MI mortality risk. So this is not at all suitable. Whether CV benefit is there or not, so no CV benefit is there CVD. Thiazolidine derivative like pioglitazone and rosiglitazone, again it will increase the chances of heart failure, but it can decrease the risk of stroke. So in a CVA risk factors prevention, this drug can be used, but for CVD risk factor cardiovascular disease, this should not be used. Again, the insulin, again the chances of hypoglycemia, weight gain, and possible CV risk factors, none for cerebrovascular diseases. So what is the best drug in diabetes with the CVD, CVA, and peripheral vascular disease? The benefit comes to be SGLT2 inhibitors. Empagliflozin, dapagliflozin, canagliflozin, all are the very good drug to prevent CVD, cardiovascular risk factor, because they reduce heart failure, they reduce CKD risk factor, they reduce CV mortality. So many studies done by EMPA-REG studies, death rate was reduced, DAPA-HF studies suggest that there is reduced heart failure chances. GLP-1 analog agonist like liraglutide, semaglutide, they are neutral or slight decrease in heart failure risk. They decrease atherosclerosis. Thereby, they are very good for CV and peripheral vascular disease. DPP-4 inhibitors is neutral except sexagliptin. One study done on sexagliptin, Savot-Timi study 2013, which increase they are associated with increased heart rate. So other than sexagliptin, sita, lina, all gliptins are neutral. They may be used. Then comes to the fifth important component. So the first is hypertension control, hyperlipidemia control, role of aspirin comes, role of anti-diabetic drugs, drug of choice, and then comes to be revascularization therapies. Revascularization therapy is two variety. Either you go for stunting therapy or CABG. And I say that if somebody is having two vessel disease or one vessel disease, not involving LAD, patient is fit for stunting. But somebody is having proximal LAD involvement or triple vessel disease, is ideal candidate preferred for CABG. So this is the first component of CVD with diabetes. What will be the pathophysiology? What are the biomarkers? And what are the treatment strategy to treat them? Now what is the key take home message? That SGLT2 inhibitors are the best, which prevent heart disease as well as renal protection. GLP-1 receptor antagonists are best for atherosclerotic CV disease. Sulfonylurea and insulin cause higher chances of hypoglycemia risk, and they are not at all good for CVD prevention. And TZD should always be used cautiously because pioglitazone is associated with increased risk of heart failure. The second component of today's talk is cerebrovascular accident. I said that everything is same in cerebrovascular accident and CVD. So I will discuss in short for cerebrovascular disease. Diabetes significantly increase the risk of cerebrovascular accident, including stroke, TIA, stroke, including both the type of stroke, ischemic stroke as well as hemorrhagic stroke, transient ischemic episode, and vascular dementias. The mechanism behind this elevated chronic hyperglycemia, insulin resistant, associated with vasculopathies, and this vasculopathy causing either the atherosclerosis or there is these arterial wall become thin or fragile, leads to damage, leads to hemorrhage. So cerebrovascular accident in diabetes, ischemic stroke, the most common variety of stroke is ischemic stroke. The mechanism is hyperglycemia, accelerate atherosclerosis, endothelial dysfunction, leads to arterial narrowing and plaque ruptures. Diabetic have 2 to 4 times higher stroke risk than non-diabetic. Major studies done in UKPDS studies 1998 showed that the tight glucose control reduced macrovascular as well as microvascular complication had a limited impact on stroke prevention. What is UKPDS study was suggestive that microvascular complication, when you tightly control the sugar level, they can be reduced, but macrovascular complication have no much effect. Accord study in 2008 suggests that invasive glucose lowering didn't significantly reduce stroke risk, but increased mortality in some cases. So both the study, UKPDS and Accord studies, were against the finding that you strictly control the sugar, the things will be reverted to normal or to less extent. Hemorrhagic stroke is less common than atherosclerotic or ischemic stroke. The mechanism already said that diabetes weakened the small vessels, increasing risk of ruptures. The other risk factors may be hypertension and microvascular damage. Third type of stroke is TIA, temporary blockage of Brown artery, often leading a warning sign. Diabetic impact higher progression rate to full stroke compared to non-diabetic. And because of the microvascular hyperglycemia, insulin resistant, impaired perfusions, neurodegeneration starts, and they can lead to cognitive decline, and they can lead to vascular dementias. So diabetes is very, very prone to develop vascular dementias. So what type of cerebrovascular diseases can occur in diabetic patients? That there is the maximum chances of stroke will be ischemic stroke. Less common is hemorrhagic stroke, then transient ischemic episode, and then vascular dementias. Vascular dementia because of recurrent infarct, recurrent small vessel involvement leads to dementias. This is what the mechanism is, that there is a hyperglycemia. They are saying that the hyperglycemia is called glucotoxicity to endothelial dysfunction. They directly involve the cells of the brain, and this can cause glucotoxicity. Insulin resistant leads to systemic inflammation, pro-inflammatory cytokines, leads to increased atherosclerosis. Nitrous oxide will reduce, the atherosclerosis will be there, and there is thrombus formation. This is all mechanism what we discussed in CVD as well as in cerebrovascular disease. Same, there is glucotoxicity, there is insulin resistance, there is increased cytokinase, there is less nitrous oxide productions, all will lead the atherosclerosis and reduce the cerebral vessels diameters, and there will be increased rigidity, means peripheral vascular resistance will be increased, leads to all these complications. So how to reduce cerebrovascular risk in diabetic patients? So now these people are very prone. So what to do? So before going, how will we diagnose these patients for cerebrovascular accidents? So I already said that the inflammatory marker is same. One very important test, you can go with color Doppler, carotid, and you can see how much atherosclerotic plaque is there. Patient may be asymptomatic so many times. So many times they may be symptomatic. And you should consider it as a high risk for investigation. Even you should have to investigate timely. You are go with color Doppler of carotid. You see for carotid bruit is there or not. And then you can go with MRA, which will be helpful to see how much carotid are sclerosed, how much lumen is there. And then how to reduce cerebrovascular risk in these diabetic patients. The first and far most important thing is that you have to see for everywhere the same. You have to see and you have to control glycemic control. Absolute control the sugar level, the complication will be the less. So what should be the ideal level in young patient? The fasting blood sugar you can have less than 100. The postprandial blood sugar should be less than 140. 1 hour blood sugar level should be less than 180. It should never cross more than 200. What should be the ideal glycosylated hemoglobin level? It should be around 7, means it should be between 6 to 6.5. It may be 6.5 to 7 or 8 in older patients. They all are saying that there is decreased chances of cerebrovascular risk factors. Then second is blood pressure management. You have to maintain blood pressure less than 130/80. They are less associated with cerebrovascular risk factors. Then you control statin by giving lipid control. By giving statin, reduce the chances of stroke. And practically, statin are responsible for reduced stroke chances. This is a partial trial done showing that the ischemic stroke will reduced, not hemorrhage. There were few studies which were saying that by giving statin, there are increased chances of hemorrhagic stroke. So there is controversy is always, but definitely statin are helpful for reduce ischemic stroke, TIA. SGLT2 inhibitor and GLP-1 analogs, neurodrug like empagliflozin, liraglutide, shows potential stroke reduction benefits and hence they should be used. Already said that empagliflozin is a very good drug or dapagliflozin is a very, very good drug along with liraglutide or semaglutide are very, very important drug. They will be helpful not only the management of congestive heart failure, but they will reduce CVD and risk for cerebrovascular diseases. Lifestyle modification like regular exercise, low sodium diet, low fat diet, smoking cessation are all helpful for prevention of cerebrovascular risk disease. Antiplatelet therapy like aspirin or clopidogrel is useful markers for secondary prevention in high risk individuals. So what are the cerebrovascular risk traditional with anti-diabetic drug? Traditional anti-diabetic drug including sulfonylurea or thiazolidine derivatives and insulin may have varying effect on cerebrovascular risk. This is what I said in coronary disease, CAD, coronary artery disease. Sulfonylurea are associated with increased chances of stroke because of hypoglycemia, because of weight gain, or because of vascular dysfunction. That was UKPDS study in 1998 was done, and the result was not promising that there are associated higher risk for CVA. Then your pioglitazone is neutral for cardiovascular disease, but it will reduce incidences of stroke risk. Rosiglitazone was associated with high chances of heart failure and it is banned now. Pioglitazone is again a drug which is associated with high risk of congestive heart failure. So in CV risk, it should not be, but for cerebrovascular risk, it is beneficial, it should be used. The study was done in IRIS study in 2016. Again, insulin is a drug which can have increased weight gain, pro-inflammatory effect and hypoglycemia. So it will increase the risk of cerebrovascular accident, cerebrovascular diseases. So in conclusion, sulfonylurea and insulin are associated with higher cerebrovascular risk, mainly due to hypoglycemia, weight gain. Pioglitazone may reduce the stroke risk, especially in insulin-resistant patients. Neurodrug like GLP receptor agonist, liraglutide or semaglutide, along with your SGLT2 inhibitors, shows better for stroke prevention and beneficial. They should be used traditionally. They should be used and they are recommended now, both with cardiovascular disease as well as cerebrovascular disease for prevention and for treatment. Now the last component I already said that the third medium size or large size artery in the body is your dorsalis pedis or popliteal artery. And involvement of these arteries is called peripheral vascular disease. So when microvascular complication occurs, it is called peripheral neuropathies. And when macrovascular disease occurs, this is called peripheral vascular disease. So two are all complication of diabetes. A small vessel involvement leads to peripheral neuropathy. Why small? Because whatever vessels supplied to nerve, nerva vasorum, leads to, these are the small vessels. That's why there will be peripheral neuropathy, where peripheral vascular disease is the large, medium-sized artery involvement. And such as large or medium-sized artery involvement is your dorsalis pedis and popliteal arteries. What are the causes and risk factor for PVD? The causes and risk factor for PVD is diabetes mellitus. The first important risk factor is high blood sugar level, diabetes. If there is a diabetes, more will be the atherosclerosis, what I said, the lumen will be reduced, the vessel requirement, the blood supply to the peripheral tissues required more perfusion, which will less be supplied. And when person do some exercise, more oxygen will be needed, that will not be fulfilled, and patient will have ischemic symptoms in lower limb practically, distal part. So high blood sugar level is one of the predictor or predisposing factor or risk factor for peripheral vascular disease. The another important risk factor is dyslipidemia, higher cholesterol level, accelerate atherosclerosis, leads to narrowing, leads to PVD. Hypertension, increased pressure will damage arterial damage, endothelial damage, more atherosclerosis, less supply. Smoking, as you all know, smoking is risk factor for so many conditions like CVD, CVA, cerebrovascular disease, cardiovascular disease, as well as peripheral vascular disease. Because whatever nicotine is there, this nicotine causing vasoconstrictions, and this vasoconstriction leads to decreased circulation. One very important disease called by this smoking under the peripheral vascular disease is predominantly this disease is seen in males. So one important risk factor is smoking, and they are saying there are so many studies suggest that cessation of smoking may have improvement towards the peripheral vascular disease. Obesity and sedentary lifestyle aggravate insulin resistant and vascular damage may be the another predisposing factors or risk factor for cardiovascular disease, for peripheral vascular disease, sorry. What will be the clinical presentation of the patient of peripheral vascular disease? As we all aware that these patients will have reduced blood flow. So reduced blood flow to the distal part of the extremities will lead ischemia, and these ischemia will cause pain. So when the pain will be there, they say that 50% of the patient of PVD will initial phase, they will be asymptomatic. They will have no symptoms. But the rest of 50% patient of PVD will have symptomatic, peripheral arterial disease or peripheral vascular disease PVD. They will be symptomatic, and symptomatic will when the requirement of the blood is more. So when person is going for the exercise, person is going for running, even patient is going for walking, they will have pain where they will have pain in the lower limb, they may have cramping, they may have pain in the calf, thighs and buttocks. And very important site of vascular claudication, and to rule out neurological claudication, there are so many neurological conditions where the claudication or pain will be there, is important is site. So if there is distal involvement, distal limb involvement, it favors more of the vascular rather than neurological claudication. Neurological claudication is more at buttocks. So these are the common site. After exercise, the patient will have pain. So pain, cramping sensations are the important feature of PVD, peripheral vascular disease. And these all will be relieved by taking rest. Somebody is taking rest for 5-10 minutes, half an hour, things will be reverted back to normal. And there is a typical feature that these intermittent claudication is reproducible and occur every time on exercise with same intensity and duration. Suppose somebody is having pain in the calf after walking for 1 kilometer, then definitely he will have pain on 1 kilometer walking with same intensity walking. So these all are practically claudication is reproducible, and reproducible claudication is very, very important feature of your PVD. This is what pathophysiology is. That risk factor is high blood sugar, cholesterol, hypertension, smoking and obesity. This is symptom, this is complications. The complication may occur, patient may have chances of critical limb ischemia, gangrene and amputation. Now, this is all diagnosis and then treatment part. So how will we diagnose peripheral arterial disease or peripheral vascular disease is from clinical history. I already said that we should have to take detailed history and claudication distance, vascular claudication. Then general physical examination we should have to do. So in general physical examination, what we will do? We should have to examine peripheral pulses. We should have to see the skin. Whenever there will be reduced blood flow in PVD, the skin becomes thin, skin becomes shiny. There will be loss of hair over skin. All this will be lost. This is because of decreased blood supply. These changes will occur. And then when you see the pulse, dorsalis pedis will be absent. So physical examination is very, very important. After physical examination to diagnose PVD, you have to go for routine testing when you go for routine testing, all these investigation, including CBC, ESR, RFT, LFT, lipid profile are important. ECG is very, very important investigation in peripheral vascular disease to see the arrhythmias, because more will be the irregular rhythm. The patient are prone for embolizations and peripheral vascular disease. Inflammatory marker, there are a lot of studies which suggest that high will be the CRP, high chances of PVD, peripheral vascular disease, because again, it is a chronic inflammation leads to peripheral vascular disease. Non-invasive evaluation, a very important investigation which I will advise, and that is ankle brachial index, ABI. Very simple method by which you can detect is you can have a blood pressure in the ankle and you have brachial blood pressure, and you see what value is ankle versus brachial. If the ratio is 1:1.4, it's normal. If the ratio is 0.7 to 0.9, it indicates mild PVD. If 0.4 to 0.9, it indicates modern obstructions, moderate. And if it is less than 0.4, it indicates severe obstruction. The another way, this is a simple method by which you can take blood pressure in upper limb and lower limb. At ankle, you can have determination. The second way is by the color Doppler. By color Doppler, you can see, and the index, you can detect it. Both are the important predictor for PVD, peripheral vascular disease. If there is a severe obstruction, this patient is going to develop gangrene or diabetic foot very soon. So you should be cautious for treatment. How will we treat a patient of PVD? This is probably the last 2-3 slides left, because time is only 3 minutes left. So the first important part is smoking cessation. You stop, patient is asked to stop smoking. The things will be reverted. Best glycemic control. You have to do sugar fasting less than 100, postprandial less than 140. Control hypertension less than 130/80. Control dyslipidemia, LDL-C less than 70. Antiplatelet therapy in the form of clopidogrel, Disprin, or both. Patient will have symptomatic PAD in the form of pain. You should have to treat the pain. Pentoxifylline can be used 400 milligram 3 times a day. Initial study was very, very promising, but later it was found that pentoxifylline is not very effective in treatment of PVD. So now a lot of people are not using, but till the old person like me is using pentoxifylline for PVD, they are saying that there is a rheological actions. They can modify RBC shape, and this RBC will more penetrate towards the ischemic penumbra, and that can reduce the pain. So that was the initial mechanism given with pentoxifylline. Nowadays, people are a lot of using, and there is a promising result of silestazole. Silestazole is a good drug to reduce these vascular claudications. And the last component is diabetic foot management. If thereafter PVD patient develop diabetic foot, this diabetic foot can be treated by proper antibiotic, proper dressing, proper care, surgical and medical both, which is a separate topic as diabetic foot management. Which anti-diabetic drug again is helpful for PVDs? And again, they are saying that 3 drugs again. One is SGLT2 inhibitor, GLP-1 analogs, and metformin. They are beneficial in PVD. All other are having high risk. So now I can summarize all 3 diseases, PVD, CVD, and cerebrovascular diseases can be controlled or can be prevented with good glycemic control. You should have to maintain glycosylated hemoglobin less than 7. Monitor fasting and postprandial sugar regularly. You can reduce the blood pressure. The target is less than 130/80. Use ACE inhibitors, ARBs, if there is microalbuminuria present, or even otherwise, these are thought to be the drug of choices. So ARB and ACE inhibitor should be used liberally in all patients with diabetes for preventions. Statin, you should have to use if patient is having age more than 40 years. LDL cholesterol should be reduced less than 70 milligram per deciliter. Lifestyle modification like healthy diet, low sugar, low saturated fat, regular physical exercise at least 150 minutes a week. Weight reduction, BMI should be less than 25 kilogram per meter square. Regular screening like annual eye checkup for retinopathy, urine microalbuminuria for nephropathies, foot examination for neuropathies and peripheral vascular disease, ECGs, treadmill testing, calcium scoring by non-invasive angiographies periodically. Smoking cessation is strongly advised to prevent vascular damage, and antiplatelet drug like low dose of aspirin for secondary prevention. For primary prevention, doubtful if age is more than 40 years and if CV scoring is more than 10, you should use liberally by giving 75 milligram per day, low doses. Thank you very much. Thank you.
So thank you very much, Dr. Mahesh Dave, and it was such a nice lecture. I just missed the initial few moments because I was returning from hospital. And very important topic you have taken, and very nicely it has been covered, because we all know that in diabetes, the major cause of morbidity, or you can say mortality, is the macrovascular disease.
Yeah.
And we are actually burdened by already non-diabetic coronary artery disease, and on top of that, if diabetes compounds that problem, then the disease goes multifold. So
Yeah.
it's not only the cardiac disease, but the increasing incidence of stroke, the peripheral arterial disease. Because India ranks amongst the topmost country where the lower limb amputation is occurring because of diabetes and peripheral arterial disease. And we had a double whammy because of use of tobacco, too much of tobacco and smoking, which lead to the peripheral arterial disease.
Yeah.
So I think we have covered yet another very important topic, and all the delegates and the students have benefited because of this. And if there are any questions or queries, you can put it into the chat box. And you all know that Dr. Mahesh Dave is a very senior physician and diabetologist, and he is the head of the Department of Medicine at Udaipur R&T Medical College. And he'll be more than eager to answer your queries. So thank you very much once again.
Thank you, Dr. Puneet. Thank you. Thank you very much. Thank you. लो डॉक्टर साहब हो गया खत्म